time.
Sorry for the technical difficulty, but we'll go ahead and start. Yeah, if you can turn that on. Great. So this next session has to do with validation of diagnostic test studies. So what we're going to do is to look at the interpretation of diagnostic tests and then how you assess and critically appraise a diagnostic test validation study. Okay. So we're going to start with how you measure the validity of a test. And the first question is, what is validity? And how do you define what validity is? It has to do with how close the result of the test is to the truth. Okay? There are 4 characteristics of a test that define its validity: sensitivity, specificity, positive and negative predictive value. Now, in order to assess how close these tests are to the truth, you have to have a gold standard. Just like an exam. If you have a multiple choice exam and you give it to me, how do I know that these questions are correct? It has to do with the key. The key tells you what the truth is, and then you measure how close this test is to the true answer. So the gold standard, however, can have some variability in its own quality. You know, may not be a gold standard, but maybe a silver standard if the gold standard is not as good as you might hope it would be. So we're going to start with taking an example of the exercise stress test in the diagnosis of coronary artery disease. So you have this gold standard, which is the coronary catheterization, and the gold standard tells you who's diseased and who isn't. So that's in the columns, all right? So you have the diseased people are A plus C, and the non-diseased people are B plus D. Now you cross-tabulate that with the test results, okay? This row here, the top row, represents everyone who has a positive test. In the bottom row, those who have a negative test. Now it's really important when you see this word positive and negative in this situation, you want to make sure that you don't say the person is negative for disease or positive for disease. No, the terms positive and negative have to do with the test result. So in this case, the test is positive, and is it true? Up here. Yes, because these people have the disease. This one, the test is negative, but that negative result is false. And likewise over here. So another really important point here is that the prevalence of disease, well, how would you calculate the prevalence of disease in this? It would be A plus C, the number of people who are diseased, divided by everybody. So A plus C over the total. That characteristic of the prevalence is really important. And that's also another term for it is the pretest probability, and we'll talk about that in a while. So let's quickly go through these. I'm sure all of you have seen this multiple times, so I'm just going to do it quickly to refresh your memory. So sensitivity is interested in those who have the disease. So it says, among those with the disease, what percent are testing positive? Okay, so in this case, it's 166 over 219, or 76%. Now, would you say that's high or low, 76? It may sound like it's high, but actually, that's not really good, not very good, okay? So 70, in that range, when you see that, you realize I'm dealing with a test that has a lot of false negatives, okay? So, 24% are false negatives, okay? Now, specificity looks at the other column, okay? Those without the disease, and that asks the question, of those without the disease, what percent are testing negative? Okay, pretty straightforward. In this case, it's 112 over 133, or 84%, okay? Again, 84 is not that high. Now, the point, though, is it may be high enough. We don't know yet. The 76 may be high enough, but it may not be. So when you're making a decision about whether to trust a test result or not, it's not enough to just look at the sensitivity and the specificity. You have to also factor in the pretest probability and look at the positive and the negative predictive values. So the way I would perceive what is a positive predictive value is, can I trust this positive test result that I have in my hand? Okay? So that's asking the question. Now flipping the consideration to the horizontal way of looking at the 2x2 table, that's saying, of those who have a positive test, what percent are actually diseased? Now I hope you can see that's clinically much more relevant than just saying, of those with the disease, what percent test positive? Because what you have in your hand is not everybody who is diseased or not diseased. What you have in your hand is a test result. So you have a positive result and you want to know, well, can I trust that positive test? Okay. Now the positive predictive value, you look at it, you say positive, it means I have a positive result, and how much can it predict the presence of the disease? Okay. Another term for this is the post-test probability. So after you have the test in your hand, what's the probability of disease if I have a positive test in my hand? And in this case, the positive predictive value is 89%. What you have to realize is that after you do a test, and if you get a positive test, that doesn't mean that the probability of disease is 100%, and then if you have a negative test, the probability is 0. No, there's a continuum of the probabilities, the post-test probability of disease. The other point is there are differing thresholds for action, clinical action. If you want to diagnose someone with HIV, would you allow a positive predictive value of 70%? I have a positive HIV test. There's a 70% chance of disease. Am I willing to tell the patient, I'm sorry to tell you, but you have HIV? You willing to do that? No. You would need that post-test probability to be much closer to 100% before you start making declarations of this serious disease like cancer or HIV. However, if you have a disease such as urinary tract infection, which requires 3 days of antibiotics, would you be willing to treat on the basis of a 70% probability? Sure. So a very important point, the threshold for clinical decision making is not always 100% or 99%. You don't have to get up to 99% for everything. Some of them are, you can make a solid clinical decision with a lower post-test probability, okay? Now, the negative predictive value, what do you think that is? It's when the test is negative, what percent of the people don't have the disease? Is it predicting negativity well? And so it's saying of those with a negative test, what percent don't have the disease, or 112 divided by 165, or 68%. Okay? What does that 68% mean? I have a negative test in my hand. What's the probability that they actually still have the disease? 1 minus the 68. We're at 32%, right? So can I tell this patient, no, you don't have the disease. You don't have heart disease. In this case, it's a stress test. I can't really say that, can I? So, and you say, well, how am I supposed to figure all this out? Now, here's another definition here for negative predictive value is the post-test probability of non-disease, right? Post-test probability of non-disease given a negative test. What's the predictive value of this negative test? Is it doing a good job or not? In this case, it's not. Now, I alluded to this already. 1 minus the negative predictive value is just the flip-flop of that, right? So it's the post-test probability of disease given a negative test. So in this case, it's C over C plus D, Negative predictive value is D over C plus D. Okay? So if it's 68% negative predictive value, 1 minus is the 32%. Okay? So in this case, it's 1 minus the 0.68, or 32%. So I have a negative test in my hand. The probability of disease is 32%. Now, how do we use this practically? Suppose I want to rule out a condition. To assist in ruling out, in other words, to have a high negative predictive value, will increasing sensitivity or specificity have the greatest effect? Sensitivity, that's right. Now that feels opposite to what it should be, right? Because specificity has to do with those without the disease. But in actual fact, you need to maximize sensitivity. So how does that work? You see, I'm interested in the negative test, and I want to rule out. What number has to be close to 0 if I'm going to trust this test? C. C needs to be low, right? How do you make C low? By increasing sensitivity or specificity? Sensitivity. So that's why, to help you rule out, you need a test of sufficiently high sensitivity. So a test, and this are one of the founders of evidence-based medicine who comes from McMaster University, Professor David Sackett, came up with this mnemonic. Snout. Do you all know what a snout is? It's an animal's nose, so that's why he didn't choose it for that, but it's a test with high sensitivity, or we should say high enough sensitivity, when it's negative, helps to rule out the diagnosis, snout. And then if you want to believe a negative test, to do this you need to minimize false negatives, or C, right? To do this you have to have a test with sufficiently high sensitivity. Now, you will also see in a minute that the pretest probability also has an effect on this, and can have a very large effect or a smaller effect on it. And the other aspect is increasing specificity does increase the negative predictive value, but it doesn't have as great an impact as the sensitivity does. Okay? How about ruling in? If you want to rule in, do you need to have a test with high sensitivity or specificity? Specificity, right? And again, if I want to trust this test, I need B to be small. What's the best way for B to become small is to increase specificity over here, okay? And so the mnemonic is SPIN, a test with high specificity when the test is positive will help to rule in the disease. If you want to believe a positive test, you must minimize the false positives. To do this, you must have a test with sufficiently high specificity. Remember what I said. Is specificity of 84% high enough? Well, we don't know yet. It might be, it might not be. Okay? Is a specificity of 95% high enough? Well, we don't know yet. It sounds high, but in certain conditions, it may not be high enough. You may need 99%, okay, or better. Sensitivity has less effect on positive predictive value than do the specificity and the pretest probability. Now, this graph basically shows the probability of disease, starting with 0 and 1. And we have this pretest probability, which I alluded to earlier, and then you have the post-test probability of disease after a positive result and post-test probability of disease after a negative result. What is this number here? The post-test probability of disease given a positive test. It's the positive predictive value. What's this one? The post-test probability of disease given a negative test. 1 minus the negative predictive value. Very good. So now what we're going to do here, we're going to start with some pretest probability. If we have a positive test, the probability of disease is going to go up. And if we have a negative test, the probability of disease will go down. Now, let's say we have a test which you start with a pretest probability, and this ends up high, very close to 1. And if it's negative, it ends up very close to 0. This is a test with higher sensitivity, right? And that's a test with higher specificity. But if the test is lower, has lower specificity, this is going to go down, right? If the test has lower sensitivity, this is going to go up. So when you have a test with lower sensitivity and specificity, it's not going to categorize the people as accurately as if you have a high sensitivity and specificity. Now, the next thing I want to talk about is this pretest probability and what exactly that is. So the pretest probability can have a profound effect on the post-test probabilities, especially when the sensitivity and specificity are low. And using the positive and negative predictive value properly requires an understanding of how to estimate the pretest probability. And you should not base your trust of a test result solely on the specificity or sensitivity, even if they're 95%. That's not good enough for you to really make a clinical decision. And I hope that's one of the points that you take away from here. And I'll show you why. So what is this pretest probability? In a validation study like this one, where you have 352 people, the pretest probability is simply the prevalence of disease. So when you have a paper, that number is very important for you to find in the paper. What percent does the gold standard say has the disease? Okay? But when in clinical practice, not in a paper, but when you're seeing a patient, the pretest probability of disease is your estimate of the probability of disease in a patient before you do the test. Okay? Now, the effect of this pretest probability, it can pull positive and negative predictive value around. Okay, if your pretest probability is high, it's going to tend to pull both of those high. And if it goes low, it'll pull both of those down. Okay, so positive predictive value is maximized when the pretest probability goes up. The positive predictive value goes up. When the pretest probability goes down, the negative predictive value is increased, and that 1 minus negative predictive value is pushed down. So what are the two things that make the post-test probability for the positive predictive value go up? Specificity and high pretest probability. What makes the 1 minus negative predictive value go down? High sensitivity and low pretest probability. Now, do you think you as a physician can really estimate this? I'm going to make a few statements, and you tell me, this is recall from medical school, okay? The history and physical examination form the foundation of the physician's clinical judgment or diagnosis, prognosis, and therapy. Do you remember your professor telling you that in physical diagnosis? And you say, well, this is a physical diagnosis course. Of course they're going to say that. Do you agree with that, by the way? Or is it just talk? Yeah, How about this statement? Your clinical exam is far more powerful than laboratory tests or any radiology procedure. Do you think your clinical exam is more powerful than an MRI? Yes or no? How many people say, my clinical exam is far more powerful than the MRI? Anybody want to? Okay, it doesn't look like anybody. But that's what they told you in clinical diagnosis, did they not? How about this? The ability to judge the pretest probability is one of your most valuable tools as a physician. Do you believe that? Do you think you estimate the pretest probability at all when you're seeing patients? Do you do that? Okay. Let me give you an example. So there's a 65-year-old man. He comes in to see you. So what are you going to order? An MRI of the brain? Urinary culture? Well, no, but I thought the MRI was really, really powerful. Now, so at this moment, how many diagnoses are on the table? Like, see, right now you've got how many? 3? 10,000? There are 10,000 diseases on the table right now. You have no idea what he's coming in for. And he tells you, I've had chest pain. It's happened 7 times in the last 7 weeks, okay? How many diagnoses after 3 seconds have you narrowed it down to? Is it still 10,000? What happened? Now, so let's take, he could have had kidney stones. So what happened to kidney stones just with that one test? There's a pretest probability of kidney stones. It just went down after that test, which is, what are you here for? That question is like a test with a pretest and a post-test probability. So what just happened to, kidney stones went down. What just happened to GERD? That went up a little bit, right? That went up quite a bit. How about pneumothorax? Well, that's chest pain, but pneumothorax doesn't usually recur, so it's still kind of in the mix, but I'm not sure about that one. How about angina? Oh, that went up. And then now, sometimes it's exertional, sometimes seems pleuritic, usually lasts 10 to 20 seconds, sometimes longer, not associated with diaphoresis or lightheadedness, and lasted 10 minutes this morning, that's why he came in, after climbing his birhi tree. He wanted to get his good dates down. And so, now what happened to GERD? You see, pre-test, it had gone up. Now post-test, post this test, what happened? It went down, and what happened to angina? It went up. And so what is this thing called? What is this process called? And you do it every day. Differential diagnosis, right? So now, what do you think the pretest probability is that this person has coronary artery disease? Do you think it's 15%? With that history? Do you think it's 50%? Do you think it's 80%? Do you think it's 90%? How many think it's about 90% given that history? You just you estimated the pretest probability. This guy has a high pretest probability. And then you can ask him, do you have diabetes? You can refine it further, okay, through your history. Now do you see why this tool is so powerful? Within minutes, you can narrow down from 10,000 diagnoses all the way down to a list of 4. That's differential diagnosis. That's why your clinical history taking and your physical exam is so powerful and so much more valuable than any test. Because if you ordered the MRI, you'd have to wait 6 weeks or 2 months before they got an appointment, and then that doesn't make sense, right? This sets the stage for everything that follows. Okay, so my guess was pretest probability over 90%. I think we all kind of got it in the same range. If you said it's 85, oh no, that's different from 90. It doesn't matter. You get it in the right ballpark. Is it high, very high, medium, low, very low? You get it into the right ballpark and you can do this procedure. So this thing is called differential diagnosis. So what do you need to calculate these things? You need the pretest probability, your clinical judgment, and you need the sensitivity and specificity. If you have those 3 things, you can calculate the post-test probabilities. Now, in our community medicine course, which many of you have taken, we had you do the 2x2 table, and on exams we had to make you calculate it out. But if you take this, now, do you all have handouts? I see you taking pictures. All of this is in a handout. Are they getting the handout?
They got it on the flash.
It's okay, so it's on the flash. I mean, you're welcome to take pictures, I don't care. But anyway, I like this website called medcalc.com. It has, see, there's one function there where it says enter the prevalence, the sensitivity and specificity, calculate, and it'll bring you the positive predictive value, the negative predictive value. It doesn't calculate 1 minus, but that's pretty easy. So this would be 72. And don't worry about the likelihood ratios. We don't have time to talk about those. But just focus on this. Very simple. Okay? Now, in this patient, you do the stress test, and it comes back positive. What could you tell the patient if that's the positive predictive value? What would you say? Your stress test came back positive. You have heart disease. And we know that the next step is going to be the cardiac cath. What if in this person you did the stress test and it came back negative? What would you say? Could you tell him, I'm glad to tell you your stress test is negative, you can go home, you don't have heart disease? Do you see? The post-test probability of disease still, even in the presence of a negative test for this man, is what? 72%. Don't let the diagnostic tests make a fool of you. And this is a case, I'll show you a little bit more. What are the cases where you can be made a fool of by the diagnostic test result? Okay, so 1 minus negative predictive value is that. So let's go on. Now let's say we have another patient. Let's say a 42-year-old woman with a history of anxiety disorder, has some family history and a few risk factors for heart disease, but she's premenopausal, and you decide that this is a low pretest probability. Maybe 10% chance, but there's not more than that, okay? And now we're going to use the same test with the same sensitivity and specificity. And you run it. Now look at the positive predictive value. What happened? I thought the positive predictive value on this test was 97%. But what happened in this patient? It's only 35%. So if you had a positive test in this patient with a low pretest probability, would you say, oh, you have heart disease, you have a positive test? You couldn't do that, right? Because what's the probability that they don't have the disease is 65%. But what would happen if her test is negative? Look at that, a 97% negative predictive value, which is the opposite of the other one, right? So what's going on? This is what's going on. So in this man, you have the same test, same sensitivity and specificity, and you're starting at a high pretest probability. This was one with a little bit lower. And you end up with 95% post-test probability and 53%. If this were 90, I think it was 97 and 72, right? So that, if this went up to 90, it would pull this up some, okay? Now, what are these people here? These are the false negatives. These people, 53%, still have the disease, right? Over here, you start low, and what did moving the pretest probability down, it pulled both positive predictive value and 1 minus positive predictive value down with it. Do you see? So now, when I'm in a low pretest probability situation, I can trust this negative test, right? But I can't trust the positive test. So do you see how in this person, is the sensitivity high enough to tell him he has disease? Sensitivity is high enough, 76 is high enough. But specificity is not high enough to tell him he does. Oops, did I get that mixed up? Yeah, I got it mixed up, didn't I? See, it's easy to flip them around, right? So, but the specificity is high enough, 84 is high enough to tell him that he has disease, okay? But the sensitivity is not high enough to tell him he doesn't have disease. But the opposite is true over here. Here, the sensitivity is high enough. This 76 is high enough because you're starting so low. But the specificity is not high enough, do you see, to trust the positive test. So in this person, you need, if you want to trust this positive test, you need a much more specific test in order to rule in. For this one, you need a much more sensitive test in order to rule in. Does that make sense? Now let's take the HIV test and see what happens. HIV test has sensitivity of 99.5 and specificity of 99.9. Very, very highly sensitive and specific test. Now, do you see that almost no matter where you start, if you get a negative test from 60, you're still below 1% post-test probability. And up here, you're still almost 100% sure. And even if you go down to 1% pretest probability, which you're probably not going to do that you're not going to do an HIV test if your pretest probability is 1. But even if you did it, do you see how strong this is? The specificity is so high it can take you from 1% all the way up to 91%. In that case, there is still a few people there. But do you see how that works? Why does the pretest probability not have as much effect on those post-test probabilities? Because the sensitivity and specificity are so high. When you have a test with low sensitivity and specificity, that pretest probability you need to watch out. And that's the situation. If you have low sensitivity and specificity, you have to be careful about the result. Now, do I need to go to that medcalc.com every time I make a diagnosis? And I need to check the positive and negative predictive value on everybody? No. You see, the situations where you should consider doing that are this. It's the situations where the test can make a fool of you. And what are those? I have a high pretest probability. I am sure clinically that this person has that disease, and the test comes back negative. That's the time to make sure that you have a test that's sensitive enough that you can trust that negative test. Or you say, there's no way this person has that disease. I don't think he has it. But the test comes back positive. When the test result surprises you, that's a situation in which you really need to be careful, because it's going against all the evidence. So if you have something that is going against all your clinical evidence, you better make sure you can trust it. For the low pretest probability, the positive test, make sure the specificity is high enough that your positive predictive value reaches the threshold for clinical action. And when you have a high pretest probability, if you have a negative test, you better make sure the sensitivity is high enough that you can trust that negative test and tell the patient, I'm glad to tell you you don't have the disease. Okay, so that's how you use the positive and negative predictive value. And I hope you understand that you cannot look at the sensitivity and specificity and tell how it's going to work in this patient. Oh, it's 95%, that's high enough. No, if you're starting high, you may need a 99% to rule it out, sensitivity, and vice versa. Okay. Now, let's see, critical appraisal of a diagnostic test study. There are about 8 or 9 questions, and I think what we're trying to show you is with each of these study designs, there's a different set of questions, isn't there? And with the questions, you have what you're doing is approaching the journal article with that list of questions in mind, and you're trying to read it to get the answers to the questions. So when you have a randomized trial, that list of questions in your seminar are the list of questions that must be answered in the critical appraisal of that randomized trial. This is the list of questions that you need to answer when you are critically appraising a validation study for a diagnostic test. And so we have to talk about the gold standard, we have to talk about the test, and then we have to talk about the population and then the results. So let's start talking about the gold standard. The first, to evaluate how close the result is to the truth, you have to have a gold standard. We already established that. The problem is that some diseases are not very well defined. And some of them lack an excellent gold standard diagnostic test, and maybe sometimes the new test is actually better than the gold standard. But usually that's not true, because the gold standard tends to be the most invasive test. And why are you trying to avoid that? Is to use a less invasive test, less expensive test, less onerous test to get close to what you get when you actually do something invasive. Some are diagnosed over time, and some need multiple tests and so forth. So if you look at iron deficiency anemia, okay, what's the gold standard for iron deficiency anemia is the bone marrow. And how long does it take to do a bone marrow? And then you take it and look for stainable iron. That's a very quick test. It's painful and has a risk of bleeding and so forth, but that's the gold standard. It's diagnosed immediately, or as fast as a pathologist can look at the slide. Now, myocardial infarction, on the other hand, takes 48 hours to diagnose, and you have chest pain and EKG changes and enzyme bumps and things like that. It's not as well defined, is it? It's not so clear, but there are clinical standards of how to do it. And then let's take lupus. It's not well defined at all. Someone comes in with a malar rash. Does she have lupus? Well, does she have joint pain? Well, some joint pain, but nothing else. And you get two of 7 criteria. It's not enough to diagnose. So we say, well, you might have lupus. We have to wait. So a year later, she comes in with thrombocytopenia, and then something else, and then maybe you'd make the diagnosis. That's the gold standard. It's a clinical diagnosis. There is no gold standard for lupus, you see. No invasive test that you can do to tell you. And the anti-double-stranded DNA is not very specific, right? So you have all these things, these criteria for that, and it's much more messy to get a gold standard for that, right? Now, the other thing is there are different types of gold standards. Some have a continuous measure, and we're going to look at one in the seminar today, looking at the narrowing of the coronary arteries. That's a continuous. You can have 0% narrowing, 5% narrowing, 20%, 70%, 90%. When are you going to call it disease? 30%? 50%? 70%? So a cutoff has to be chosen of where you're going to call someone diseased. There also are other types of diagnoses which are subjective. Take the diabetic retinopathy. You look in the eye and you see something, and it's how many lesions and how big they are and and they say, well, there are criteria for that, and so we have to have that kind of clinical diagnosis. There isn't a test to do. It's a clinically diagnosed one. But so when you're reading a paper, you need to identify how are they assessing the gold standard. How are they measuring the disease by the gold standard? Do I agree with it clinically? Could they have done it better? Okay? So that's rule number 1. They tell you, they describe the gold standard procedures well enough. Second rule, the second question, the gold standard must be done in all participants, okay, if possible. Now, some studies do the test, and if the test is positive, they'll run the gold standard. If it's negative, they don't do the gold standard. And you say, how does that work? It has to do with ethics, okay? So is it ethical to do an invasive procedure, the gold standard, on someone you think is not ill just so that you can get an unbiased result? No. So here's how it works. Let's say everyone presenting with fever, right lower quadrant pain, and anorexia, possible appendicitis. Now, appendicitis was always a clinical diagnosis, right? But then they come up with the spiral CT, which they see is really, really good. And so they're going to test it. And so if you do the spiral CT and it's abnormal, you go to laparotomy and see if they have it or not. But, oops, what happened? But if it's completely normal, in that study, do you think it's ethical to go and do a laparotomy on someone who, before you've even done a validation study of this CT, you're pretty sure that it's really good and it's unlikely that they have the disease? No. So the ethics committee wouldn't let you do that because they may not have the disease, and why are you cutting them open then and subjecting them to anesthesia? But what does that do to our sensitivity and specificity? Well, if the test is positive, we do the gold standard. If the test is negative, we do nothing. So everybody here is going to be shifted there. What just happened to sensitivity? Went to 100%. What just happened to specificity? It went higher. Do you see? So if the gold standard is not done in everybody, and some studies it's done that way, be careful. The sensitivity and specificity may not be as high as it's being reported. And that's called verification bias. That type of bias is called verification bias. So that's the second question, is the gold standard done on everybody? Then about the test, again, there are different types of tests. There are continuous tests. If it's continuous, you have to decide, where am I going to cut this cut point, right? And there's also subjective classification, same thing like we said with retinopathy. And then the reliability of the test should be given. Is there a coefficient of variation if it's continuous, or a kappa for categorical tests? I'm not going to get into the definition of those. I don't have time. But that's another thing to think about. Now, the test, comparison with the gold standard, must be blind. And you keep hearing about blinding, right, in all these studies. What does that mean? It means the person performing the test should not know the result of the gold standard, and vice versa, especially if there's a subjective component to either test. Okay? If a machine is doing the test, blinding may not be quite as important, but if there's a human factor, it's very important. Let's say there's a new screening blood test for cervical cancer, and you test it against the Pap smear. Okay? What could happen if the reader of the Pap smear, I'm trying to decide, is the Pap smear positive or negative? Is there disease or not? And now I know what the result of the test was. Is there cervical cancer here, the Pap smear? Well, the test was positive. Yeah, I think it's here. The test was negative. No, I guess it's not there, right? So now you've got a situation. What happens when the Pap smear is being read and they know it's a positive test? You see, this can get big. And then if it's negative, they might push it over here. What just happened to the sensitivity and specificity? They both went up. That's why it's critical that you see it written. The people assessing the gold standard were blinded to the results of the test, and vice versa. So what blinding is, and this is actually helpful in any study, blinding is cutting across this way. Whoever's measuring this doesn't know that. Whoever's measuring that doesn't know this. Okay? So whether it's a exposure in a cohort study, or exposure in a trial, intervention, yes, no. When you're measuring this, you shouldn't know that. And when you're measuring this, like in a cohort study, when you're measuring the outcome, you should not know the exposure. That's blinding, okay? Now, the fifth thing to consider is that the tests must be independent of each other, okay? And it's not as unusual as you might think. Let's take the example of myocardial infarction. Okay, the gold standard is chest pain, EKG, and enzymes, right? That's our gold standard. And what if you're testing troponin I to see how good is troponin I itself at predicting myocardial infarction? So if you do that, if you say troponin I is the test, and this clinical diagnosis is the gold standard, what if the gold standard, the enzymes include troponin I? See, troponin, the test is part of the definition of the gold standard in that case. What's going to happen? Do you think troponin I is going to predict itself? Yes. Surprise, surprise, right? And so, again, what would happen? You would have troponin I when it's positive. A would get big because it's gold standard includes troponin I. And down here, when the test is negative, it's part of the gold standard, so A and B get big, and sensitivity and specificity would increase. Okay? Now we come to a very important part of critical appraisal of a diagnostic test study. True or false? The positive and negative predictive value are affected by the prevalence of disease. Is that true or false? The pretest probability. Yes. Are the sensitivity and specificity affected by the prevalence of disease? No. The standard answer is no. They're not affected by the prevalence. The prevalence can go up and down, but the sensitivity and specificity of the test doesn't change with prevalence. However, are sensitivity and specificity affected by the nature of the diseased and the nature of the non-diseased in your study? Absolutely yes. Okay? Now, what you need to do is to think about this population and say how well defined it is it clinically relevant and unbiased? So a well-done validation study will clearly define the inclusion criteria, okay? Report the basic characteristics of the participants so you know who is in that study and how they got there. And here's one of the most important points. It should include all those in whom the test will be used, and everyone in the study should clinically be a candidate for the test. If you find people in that study who are not candidates for the test, you have a biased study. Everyone in there must be a candidate for the test clinically. If they're not, don't look at that paper. So, how do you identify the population? What's the best way to identify the population? You think through the typical clinical setting in which the test is used, okay? So for a diagnostic test, who do you do a diagnostic test on? Someone who's symptomatic, right? So everyone in that study should have the set of symptoms that qualify them clinically to get the test. If you have anyone else in there, it's no good. For a screening test, who should be in the study? Symptomatic people? No. Asymptomatic people. And don't go applying the sensitivity and specificity from a diagnostic test study and say, oh, this is really good sensitivity and specificity. We can use it as a screening test. No, because you're not going to be doing a screening test on symptomatic people. Do you see? So you've got to keep the population in mind very carefully when you're doing this, okay? These are the individuals who should be included in the study. It should not include anyone who is not a candidate for this test, and the whole spectrum of people who are eligible for the test should be included, okay? Now, the best way to identify participants in a validation study of a diagnostic test is to consecutively invite the people who meet the criteria for that test into the study. And you look for that. If they're not doing that, like if they do a case control study where they get a bunch of cases and they get a bunch of controls, that's a huge risk for bias in this kind of study. So beware the study that cherry picks the sick ones and gets a bunch of non-diseased people, and let's just see how well it does in this strange population of cases and controls. So if the test is to be used to diagnose symptomatic patients, make sure, this is redundant, it's basically saying the same thing I said already. Let's give an example here. So what you do is you say, this is a new test, the M-Izyme test. And so you see this paper and they say, oh, we have a new test here. We took a whole bunch of people with MI, and we took a whole of cases, and then we got some controls who were normal. And we ran the test on these people, and look at that. The sensitivity and specificity is almost 95% or 99%. Among those with the disease, almost all of them are being called positive by the test. Among those without the disease, almost everybody's called negative by the test. This is, mashallah, this is a great test, right? Do you see the problem? Are normals without chest pain going to be getting this test? Who are the people without MI who would be getting the test? Who are the people without MI who would be getting the test? People with chest pain, who have unstable angina or GERD or pulmonary problems or all kinds of things. That's the group of people you have to include. And maybe the M-Izyme is higher in those people. And now what happened to the sensitivity and specificity? much lower in both cases. Now, let's say we have a screening test. We want to screen for diabetes, so we go to the diabetes clinic, go to the specialty clinic to get our diabetics, and then we get a bunch of obese people with MI because we're concerned about obesity, and we want to screen obese people. Okay? And you see very high sensitivity and specificity. What's the problem here? The problem here is, are these people eligible for a screening test? Kalish, right? So you can't do that. That would be a completely biased study. So what you need is undiagnosed obese people who have diabetes. Okay? That's the group, and you'll see the sensitivity and specificity is far lower in that group. Okay? So so beware the case control study for diagnostic tests for this reason. How do you cherry pick cases? How do you get cases and controls? No, the best way is to consecutively enroll people with a certain set of clinical criteria, symptom criteria, that they require the test. That's how you get them in, and then you do the gold standard in the test. Much safer and much less biased design. So now, in the last few minutes, we have to talk about the results. So the sensitivity, specificity, positive and negative predictive value are presented. Okay, and obviously most of those validation studies will have that. Okay, now the positive and negative predictive value is based on what? Is based on the pretest probability in the paper, right? So therefore, you should never apply a positive or negative predictive value from a paper to your patient, because your patient will have probably a different pretest probability, right? If your patient could be enrolled in that study, if that patients in that study are representative of your patient, okay, then you can use the sensitivity and specificity for that patient. But never, never, never use the positive and negative predictive value from a paper and apply it to your patient. Again, that's a recipe for making a fool of yourself, letting the test make a fool of yourself. Because if the probability of the test was low, and then your pretest probability is high in this patient, and you want to trust the negative test, be wary of that. Okay? And then the next thing is we want ROC curves to be presented. Okay? If a diagnostic test is continuous, what you can do is to calculate sensitivity and specificity at different levels of that test. You say, well, if I make the cutoff for saying they have disease here, what's the sensitivity and what's the specificity? If I do it here, what's the sensitivity and specificity? Then you can generate a curve. Okay? So let's take this. If you have a cutoff here, what is the sensitivity at this cutoff? Can you see? Of those with the disease, what percent are testing positive? So what this means is at this cutoff, any M-enzyme above here is considered a positive test. Anyone below that is considered negative. So what's the sensitivity? Is it low or high? Is it high or wide high? It's very high, right? It's almost 100%. Of those with the disease, what percent are on the positive side? Almost all of them. What about the specificity? Is the specificity low or high? Of those without the disease, what percent are testing negative? Very low, right? So now, when we move this cutoff up, what happened to sensitivity now? Sensitivity went down, but what happened to specificity? It went up. And if we go up here, what happened to sensitivity? Went further down. And what happened to specificity? It went almost to 100. What if we made the cutoff over here? Specificity would stay the same, 100%, all through all of this, but sensitivity would keep going down. If we, at this point, when you go low enough that all 100% of these people have the disease, and they have a positive test rather, you can keep moving down. Does sensitivity change between here and here? No, it's 100%, 100%, 100%, doesn't matter where you are down here, but what's happening to specificity? It's going down, 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 down. So you don't get any benefit from increasing sensitivity once you get down below that. So the higher the threshold to consider someone positive, the higher the specificity. The lower the threshold, the easier it is to be called positive, the higher the sensitivity, okay? So now, this is an ROC curve, and basically it's mapping sensitivity versus 1 minus specificity. Now, the epidemiologists or whoever came up with this probably were having an evil laugh, like, we're going to put 1 minus specificity, so it's going to confuse everybody. We love it when we know what we're doing and everyone else is confused. So if by chance you see something like this on the board exams or something, here's what you do. I didn't put it on the slide, but you write specificity here, and you put a 0 over here, and you put a 1 over here. It'll help you, because you have to keep putting 1 minus specificity. So over here is high specificity, and over there is low specificity. Now, you tell me, is E the highest cutoff or the lowest cutoff? The highest cutoff or the lowest cutoff? Okay, the higher the cutoff, the higher the specificity. The lower the cutoff, the higher the sensitivity. So sensitivity is going up, 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 and then it stops. Okay? This is going up or down. Is the threshold going down as sensitivity goes up? Yes, so this over here is the lowest cutoff. What's the highest cutoff? The higher, higher, higher. What happens to sensitivity? It goes down, but as you take cutoffs higher and higher, higher, the specificity is going up toward 1. Okay? So that's how you interpret that, the ROC curve. Now, if you have low sensitivity and specificity, it's going to look like this. If you have high sensitivity and specificity, like the HIV test, it goes like this. And it goes down. There's a little tiny bit here. So high sensitivity and specificity will just look like this, like that. But if you have low sensitivity and specificity, it'll go from here and maybe like this. And if it's a straight line, does the test do anything? It does nothing. Sensitivity and specificity of 50%. Okay, the last item here is that the confidence intervals around the estimates should be presented. There are many studies that are published that don't have those confidence intervals. And you have to watch out, because many of those studies are woefully underpowered. And just because it says the specificity was 50%, or 95%, maybe there's a wide confidence interval around that, okay? And remember, when you see an estimate and a confidence interval, where's the estimate coming from? It's coming from your sample. The confidence interval is what you can say about the true value. So out there in the population, you bring some people in, you sample them, and you get your estimate. You're trying to estimate those people out there, right? But can you say, if the study shows a 95% sensitivity, that that's what the sensitivity is for the test? No, when you apply it out there. The confidence interval says, I'm 95% confident that the true sensitivity is between these two values. And so you look at the upper and lower end, and if the lower end is really low, the truth could be really low. So if it's 95 and it goes from 70 to 100, you say, the truth could be 70? Whoa, that's not very good. So you want it to be, let's say it went from 90 to 100, that's much better. So the narrower those confidence intervals, the more confidence you have in that estimate, the 95. Do you see? That's how you use those confidence intervals. Now, here are several websites, and it's in the handout when you get it, for calculating those diagnostic test results. And I think I thank you for your attention. I think we'll go now to the seminar after a few minutes. Okay, maybe 10 or 15 minutes, 10 minutes? Oh,
For the time.
okay.